name is Michelle Udine. Thank you so much for inviting me to speak today. I'm happy to talk to you about fetal cardiac MRI, its current state and future of innovation. I'm going to talk to you about my experiences here at Children's National in Washington, D.C. Fetal echocardiogram is a gold standard for diagnosis of congenital heart disease. It yields beautiful images, is safe, accessible, and highly accurate in diagnosis. However, there can be limitations, especially later in gestation, including maternal body habitus, fetal position, fetal bone ossification, oligohydramnios, all resulting in a limited field of view. In addition, there is a role for fetal CMR as a complementary imaging modality. So ventricular volume and flow data can help to provide a quantitative assessment of valve regurgitation and ventricular function. It has the potential to quantify the degree of cardiovascular compromise in certain conditions that can result in high drops. And we've seen it can improve prenatal counseling and delivery planning. In addition, some diagnoses continue to remain elusive to diagnose prenatally, including coarctation of the aorta. Some recent data has suggested that a combination of visualizing the 3D anatomy with blood flow characteristics by fetal CMR may be a more sensitive way of capturing those cases that are then diagnosed postnatally. Here's a list of potential clinical use cases for fetal CMR. Indications for fetal CMR have yet to be determined or published, but many experts have described the potential for improved diagnoses in a variety of settings, including the ones listed here. A large limitation previously in the ability to perform fetal CMR is the inability to obtain dynamic images of the fetal heart because of limited ability to gate the fetal heart. Dynamic imaging to resolve cardiac motion and blood flow requires cardiac gating, and so I'm going to describe SmartSync, which is the device that is shown here, developed by North Medical, and it's a Doppler ultrasound gating device that's increased the success of gating the fetal heart internationally. It's an alternative to ECG, and it triggers based off of Doppler waveforms and is connected directly to the MR scanner for data synchronization. There are other methods listed here, including metric optimized gating and self-gating, but this device really has changed the landscape worldwide of how we are now gating the fetal heart for fetal cardiac MRI. So there's many very exciting applications for fetal CMR, but we have to mention the many challenges. They're both fetal and maternal motion, and we are looking at very small structures within a large field of view and a fast fetal heart rate. Right now, there's not clinically available fetal ECG to synchronize the data, and the cost and potentially long scan time, in addition to the need for an experienced clinician to acquire, interpret, and communicate these important findings to the team. Despite this, there's an increasing number of centers worldwide that are starting to use this technology. When getting started, a lot of thought may go into 1.5 versus 3 Tesla scanners, and I've listened to many talks and webinars on this topic, and essentially the spread is between both, and learning to work with what you have and what is accessible is important. They both have strengths and weaknesses. So 3T, you think about there's increased signal to noise ratio and spatial resolution and potentially more detail. There's also improved ability to perform 4D flow and potentially shorter scan times. On the other hand, for 1.5T, it's safe and accessible with some limitations in spatial resolution, but there is a lower sensitivity to motion artifacts and fewer inhomogeneities. So in summary, both 1.5 and 3 Tesla magnets have the ability to perform fetal CMR successfully. I'm going to go ahead and describe our workflow at our center. Typically, these scans are best performed in the 3rd trimester after 30 weeks gestation. We utilize the North Medical MR-compatible Doppler ultrasound device, secure it to the maternal abdomen in the place where we find the most consistent fetal heart rate. And so I utilize fetal echo to help find the best position, but you also can use localizers for the MRI to position the device as well. The device is secured on the maternal abdomen with an elastic belt and then is connected to the scanner. And in terms of maternal position, supine is best, but also left lateral works as well. The biggest thing is making sure that the mom is comfortable, utilizing pillows and adequate positioning. Sometimes we have mothers listen to music or whatever is going to make them the most relaxed, because that's when we get the best scans, is when the mom is calm and feeling comfortable. So in terms of sequences, we start with scout images in 3 planes, about 6 to 8 millimeter slice thickness, typically black or bright blue images with a large field of view. And then we move on to static images of either SSFP stacks, but our workhorse is the black blood images or HASTE images. And this really allows us to see the gross anatomy, the mediastinal vascular anatomy, and extracardiac anomalies. It's a high spatial resolution with short acquisition time, and there's excellent contrast between the lung and thymus and the heart, and this does not require cardiac gating. So I'm going to talk a little bit about slice to volume reconstruction, which is a post-processing technique. We acquire about 6 to 9 black blood stacks in the traditional views, plus oblique and long axis views. They are 2.5 to 3 millimeter slice thickness, and we then can utilize this post-processing program that has been developed through King's College in London to create a motion-compensated 3D volume. And you can see in the picture here, this is kind of the raw data that is then the input data that is uploaded, and it's a very easy process onto a website where you then get the output DICOM data that is a motion-corrected 3D volume and is really nice to be able to visualize the anatomy. You can use this for 3D modeling, looking at the outflows in venous anatomy, which multiple centers have shown is possible. And then also there is an automated lung volume program that reconstructs the lungs and then also gives you a percentile of lung volumes. This is an example in a recent publication using the SVR platform for 3D modeling of an interesting case of an interrupted aortic arch. So this is the SVR reconstruction data that then was segmented into a 3D model. You can see the interrupted aortic arch and the ductal arch here shown nicely from this center. On to the Cine-based imaging, these are time-resolved SSFP images requiring gating, and they have a high spatial and temporal resolution. Maternal breath holds can be utilized, or shallow maternal breathing to minimize maternal respiratory motion artifact. That being said, some centers do have success with free breathing as well. There's no sedation utilized or contrast, and then typically we do stacks in multiple planes. The axial stack tends to be one of the highest yield for anatomy, and then following these stacks we can do cardiac specific views if desired, including the 2, 3, 4 chamber view, right ventricular outflow tract, sagittal views of the arch, for example. It really depends on the clinical question for the patient. This is an example early on in our process of a normal volunteer. You can see in this first image there's levocardia with 4 normal sized chambers and normal biventricular function. This is an axial stack, and as we go superiorly, you start to see the left ventricular outflow tract, and then further superior, the right ventricular outflow tract and right pulmonary artery. Finally, in the 3-vessel trachea view, most leftward, you have the ductal arch. There's a leftward unobstructed aortic arch. This is the trachea, and the right superior vena cava. So this is a nice example of normal anatomy early on in our process of learning how to do this. This is an interesting case of mine that led to a change in the care of this patient. And so this is a referral by fetal echo for a dilated left atrium. And so there was some concern about the potential for abnormal venous anatomy because the SVC was also dilated. And so in this first image, you see there's a large left atrium. The atrial septum appears like it is intact. And as you go superiorly, you see that this dilated right superior vena cava actually drains to the leftward aspect of the atrial septum abnormally into the left atrium. As we head superiorly into the 3-vessel view, you see that the superior vena cava is actually in the normal position here, rightward, but is dilated, and more superior to that is the innominate vein, which is also dilated. This is a nice coronal view showing the unobstructed large right superior vena cava wrapping around and entering the left atrium. There's a normal left ventricular outflow tract and mitral valve and normal biventricular function. So this was an interesting case where we did change the delivery plan in the context of an intact atrial septum to recommend delivery close to our center. And so the baby was transferred to our CICU, was hypoxic without respiratory distress after birth. And after confirmation of diagnosis, the baby underwent an uncomplicated surgery and was discharged within 1 week. So in this case, it really helped to create a mental model and clear postnatal plan for intervention for this patient. Moving on to flow imaging includes 2D phase contrast, which really is the gold standard postnatally for hemodynamic assessment. And there are preliminary reference ranges that exist for late gestation human fetuses, and it is feasible to measure flow in major vessels in the fetus late in gestation. Some of the limitations that we run into include movement, especially earlier in gestation, and then also it's localized flow information really in just the plane of interest that you dedicate. And if you want multiple vessels, it can be a long acquisition time. And a solution for this is 4D flow. And so it really allows for a comprehensive analysis of vascular and valvar flow, where you can visualize phasic flows, including ductal, atrial, and venous flows, where there's simultaneous cine and flow components allowing for blood flow quantification at multiple levels. And this is all acquired in a single acquisition. There is a considerable technical failure rate with limited spatial, temporal, and velocity resolution, and of course is susceptible to respiratory motion artifact. There is ongoing development for the potential with new technology, including compressed sensing, that does reduce the scan time. Importantly, flow phenomenon overall can be quantified with this, and hopefully in the future can be used to guide different therapies. I just wanted to show this beautiful 4D flow movie from the group in Germany of its type A interrupted aortic arch, and there's an anomalous right pulmonary artery off of the ascending aorta. And I'll just let this play because it's a beautiful image where you can see the different flow as well as the anatomy. This is a ductal arch, and then up here is the interrupted aortic arch and the head vessels. And you have the ability to measure flow at all of these different planes. All right, so what about the clinical utility of fetal MRI for extracardiac evaluation in patients with congenital heart disease? That includes looking at the fetal lungs in congenital heart disease and looking for the presence of pulmonary lymphangiectasia in cases of obstructed pulmonary veins, looking for nutmeg lung. In cases where this is a concern include total anomalous pulmonary venous return with obstruction, or cases with a restriction of the foramen ovale, for example, in hypoplastic left heart syndrome or other single ventricle physiology. The other anatomy that it can be helpful is within tetralogy of flow with absent pulmonary valve, where an anatomic airway and lung findings on fetal MRI can be predictive of postnatal compromise, including bronchial compression or signs of air trapping. The brain imaging has been very important to define structural brain abnormalities, brain volumes, and brain injury that can impact ultimately the neurodevelopmental outcomes of our patients. Importantly, fetal physiology research utilizing flow imaging and T1, T2 mapping may allow for a deeper understanding of fetal physiology, including oxygen delivery and consumption in different forms of congenital heart disease and heart failure. This article showed the predictive capability of 4D flow and black blood slice to volume reconstruction for diagnosing coarctation of the aorta postnatally, and found that a combination of morphology and flow indexed to the fetal weight had a higher predictive value than just looking at the morphology or flow alone for postnatal coarctation. So you can see here, this is looking at the anatomy and morphology using the black blood reconstruction, making measurements, and then the 4D flow measurements as well. So there are three categories I expect for referrals moving forward for fetal CMR within congenital heart disease. The first is extracardiac vascular structures, including the aortic arch. Second would be systemic and pulmonary venous anatomy. And the third would be a ventricular size assessment, including ventricular dilation, where we can accurately assess and serially monitor the heart size and function. And then the other category is to gauge adequacy for biventricular physiology postnatally in cases of one small ventricle. So for example, diagnoses including left-sided obstruction or borderline left heart, unbalanced atrioventricular septal defect, or a small right heart, for example, pulmonary atresia with intact ventricular septum. So since I'm talking with a group of radiologists, I wanted to mention the possibility of combining some of our fetal CMR assessment with an extracardiac assessment. As you know, it can be challenging due to the length of the scan. Typically, a fetal CMR can be anywhere from 30 to 60 minutes of scan time, primarily in the third trimester, which could be after some of those questions about extracardiac anatomy arise. We do have to place the Doppler ultrasound device and get a stable fetal heart rate, which does typically add somewhere between 5 and 10 minutes. That being said, our center has successfully combined our fetal cardiac imaging in some cases with the fetal body in a 1.5 hour time slot per patient. Our black blood imaging and SVR reconstructed images are great to look at the trachea, lungs, and mediastinum. And then some of our localizer images can look at just overall the organs and brain. Rarely we will add the brain as well in addition, but this does of course become a very long scan. So potentially we've thought about prioritizing specific sequences depending on the case, and of course if they've had prior imaging earlier in gestation. So in conclusion, fetal CMR is a promising technology and is complementary to fetal echo. It can improve the accuracy of diagnosis, counseling, and postnatal planning. It may help planning intervention and the ultimate plan for neonatal care within the fetal period. Indications for insurance coverage for fetal CMR are yet to be defined, and the Doppler ultrasound device has allowed more centers to start performing fetal CMR, which is very exciting. We do need trained staff and physicians to acquire, interpret, and communicate these findings, and research may allow for direct fetal cardiac gating in the form of fetal ECG, which is ongoing. This is a rapidly developing field, and I expect it will become more accessible and useful for clinical care in the next 5 to 10 years. These are my references. 10 years. Thank you all very much for allowing me to speak today, and here's my email address if you have any questions or comments.